Good afternoon. I know that we are running late of the sessions, so I'll try to be fast in presenting this lecture about Xiidra and the dry eye. We know all about the dry eye problem. It's a multifactorial disease, usually having a problem with the loss of hemostasis of the tear film, and accompanied with ocular symptoms in which tear film instability and hyperosmolarity of the ocular surface, inflammatory and damage of neurosensory abnormalities play a very important etiological role. It's very common all over the world. It differs from one continent to another, from one country to another. And it is really, the dry eye is one of the most important cause of the patients to visit the ophthalmologist. And it can impact both quality of life and quality of vision. Severe dry eye might lead to pain, a significant pain, and limitation of daily activities, poor general health, and depression. So the dry eye disease results in visual disturbance, visual acuity, results in difficulty in driving, reading, and computer use, and it can negatively impact the psychological health of an individual. As I mentioned, it is varied from a country to a country. The presence of it and the percentage differs. Middle East is one of the most common areas where the dry eye is there with a high percent. And 50% of cases are incorrectly diagnosed most of the time. And dry eye is not easy to be diagnosed as well as the classification of it. It's intermingling with different factors and it's not easily treated. So the misdiagnosed cases of dry eye disease as well as the undertreated cases of dry eye disease having a lot of impact on the patient, and usually the frequent visits of the patients to the doctors, the ophthalmologist, lead to dissatisfaction of the patients because they cannot find a permanent solution for it. Usually I tell my patients this is a chronic disease which doesn't have a real cure, but we are trying to manage your case to make the things easier for you as regard the symptoms as well as the signs. Women are more likely to receive treatment. Older people, they receive the treatment, but usually they have other medications, so usually they are fed up with the medication. The compliance of the patients usually they don't comply with the regime given by the doctor, and the proper treatment underlying cause should be managed so that we can help the patient more and more. A lot of risk factors are there: age, sex, races, climate, humidity, as well as the AC and the hot weather, systemic diseases, ocular and systemic medications, contact lens use, makeup use, and the modern life. We know that there are a lot of risk factors having affection of this dry eye disease and its presence. And as I mentioned, this dry eye disease can impact the visual acuity, the preoperative measurements of the patient's eye, the success with the contact lens wear as well, because usually the contact lens causes dryness, so that you have to dry the contact lens with the eye, and this dilemma. Cataract surgery outcomes, refractive surgery outcomes, adherence to glaucoma therapy, success of glaucoma surgeries, and patient retention. As I mentioned, the modern life that we are living in now, we are watching a lot of screens all the time, and this long time of concentration, not the screens themselves, causes frequent evaporation of the tears, as well as the concentration decrease the blinking, so even the tears produced are not going to help the ocular surface of the cornea. Dry eye have different symptoms ranging from irritation, grittiness, burning sensation, watery eyes, foreign body sensation, eye dryness, stinging, pain, and fluctuation and blurry vision. The symptoms also are rarely correlated to the clinical signs and manifestation on the patient itself. It can vary from the time of the day, in the morning different than the afternoon, according to the environment, according to the work of the patient himself. And clinical assessment of the dry eye severity may underrepresent patients' experience of the disease. So we have different types of dry eye: mild, moderate, and severe, episodic or chronic dry eye. Different classifications are there according to the aqueous deficiency and the evaporative, intrinsic and extrinsic, Sjogren syndrome and non-Sjogren syndrome, as well as there are a mix between both of the two types of the dry eye types, like the aqueous deficiency and the evaporative. There is usually a mix between them. So the main proven problem happening with the dry eye is the inflammation in both the evaporative and the aqueous deficiency, as well as the mixed type. Tissue damage leads to inflammation and dissociation stress on the cells, and this causes acute to chronic inflammation of the eye. So when we are using different types of management or treatment for the patients, one of the most important things to manage is the inflammation happening to the eyes. And this is, there comes the role of Xiidra. In the normal situation, the antigen expressed over the eye are binded from the eye cam to the LFA1, which is on the T cells, lymphocytes, and this will release cytokine in the environment of the cells and tissue, and this will cause a lot of problems and dry eye. So the Xiidra is an LFA antagonist, which is designed to block this interaction between the eye cam of the antigen and the LFA on the T cells, lymphocytes, are both active and inactive. So it was the first and the only LFA antagonist approved for the treatment of dry eye disease, with no generic alternatives, interferes with the activity of both active and inactive T cells. The Xiidra as well has the first FDA-approved drug for the treatment symptoms and signs of dry eye. It's the only non-steroidal immunomodulator to show symptoms relief within 2 weeks. So, symptoms of signs of dry eye disease are managed both with this Xiidra, and this was proven by different studies. 5 studies were done on over 2,400 participants, and 2 out of the 4 studies showed that the relief from eye dryness happens as early as 2 weeks, the relief of the eye dryness itself. And in 3 out of the 4 studies, they showed that there is an improvement in the inferior corneal staining, which happens usually associated with dry eye in 12 weeks. This is important. And 4 out of the 4 studies shows relief from eye dryness at 6 and 12 weeks. This can be associated with using other things during this treatment regime of the patient. Across the 5 studies, Xiidra proved great tolerability and low discontinuation rate. Only 7% of the patients, they discontinued the Xiidra. Nearly 80% of the Xiidra-treated patients stopped artificial tears even after 3 months. So this is a very good information that we should consider in our practice. I'll show you a couple of cases which came to me. One of them was a patient with no laser refractive surgery done before, with having a marginal grand damage, with low meniscus tear film. Breakup time was 4 seconds. Schirmer test was 5 millimeters. So I've started the Zydra for the patient. Actually, I started it with the combination of artificial tears as well. And after about 4 weeks, the patient foreign body sensation was much decreased, with less redness and much less conjunctival injection. The meniscus tear film was improved a little bit, and the breakup time was improved to 6 seconds, and the Schirmer test improved to 6 millimeters. Another patient who came in April 2025, he had a PRK 1 month before coming to me. He was not using any lubricants post-operatively, and he had a very bad foreign body sensation with redness. And he had a post-PRK corneal haze with good meniscus tear film. The breakup time was 7 seconds. The Schirmer test was 7 millimeters. So I started the patient with the Zydra as well as with artificial tears. And after about 5 to 6 weeks, he had less foreign body sensation, less redness, much better meniscus tear film. Breakup time was improved to 8 seconds, and the Schirmer test had 8 millimeters. So Zydra interferes with the activity of both active and inactive T cells. This inhibits the inflammation in general, and thus it improves the dryness happening from inflammation if present, which is usually present in most of the cases, and remains the only non-steroidal immunomodulator to show symptoms relief at 2 weeks, and it shows excellent safety profile with tolerability and low discontinuation rate with evaluation over a year. Dry eye disease treatment are different. We can use artificial tears, we can use topical anti-inflammatory drops, we can use steroids, cyclosporin, vitamins, punctal plugs, devices, combined treatment. Most of the time are necessary. And we know all the stage management, which was advocated by the American Academy about treatment of different stages of dry eye. And we know there is no rigid algorithm for treating dry eye, but we usually start by education of the patient, informing the patient that this is a lifelong problem that he has to deal with. And we, according to the etiology, if found, we can treat the etiology to improve the dryness, and we try different types of medication for the patient to relieve his symptoms. So, to summarize, dry eye disease treatment is tricky, but not impossible, needs lifestyle changes. Proper solution may involve trial and error. Many medications and devices are available for the treatment of the dry eye. It's not every treatment is good and right for every patient, so we can tailor the treatment according to the patient and his problem. Combined treatment are usually necessary. A lot of daily maintenance and continuation of follow-up the patient is very important. A lot of things coming in the future to treat and deal with dry eye disease. So in summary, dry eye is common ocular morbidity with significant impact on the quality of life of patients. Mostly the methods of diagnosis are invasive. Non-invasive technologies are now available and becoming more available in the future. Artificial tears are the mainstay in the treatment of the dry eye, but a lot of things should be done with the etiology if there is a future need for better understanding of the dry eye and how to tackle different things with the same medication or a combined medication. We have different weapons to treat. We need to use them all wisely. Thank you very much. Questions? تفضلي.
Do you have any approach to Because I have very difficult patient who's suffering from Sjogren syndrome. I've tried everything for her, and she keeps coming with corneal staining. Do you have a special approach for those patients?
Actually, I saw Sjogren syndrome very infrequent. The last time I saw patients with Sjogren syndrome was 7-8 years ago, and usually we were giving, of course, artificial tears, and we are giving the patient mild steroids at that time. Because there was no any cyclosporin at that time or the non-steroidal medication. But the patient, as far as I remember, was following up with about 3 to 6 months, and she was only depending on the punctal plugs. We closed the puncti, and we used the artificial tears frequently with the ointment at night, and a very low concentration corticosteroids.
Actually, so I tried everything, but
Sjogren syndrome, even Sjogren syndrome, it has different expressions, and sometimes it is very aggressive to the eye. So usually, many of the medication doesn't help the patient a lot, but there is no actual thing that we can do except trying different modalities of treatment.
Do you think that controlling the systemic condition affects the dry eye, or it's not related?
Again?
Controlling her systemic disease.
Of course, I think so. And as I mentioned, the systemic diseases can affect the dry eye itself. The systemic medication can affect, as well as the ocular disease, which is the Sjogren syndrome. So if we are going to treat the systemic disease itself, it can help in the improvement of the dry eye.
Okay, one last question, please. Since the Restasis and the Zidra, they have different mode of action. Can they be used together or no?
Well, actually, I didn't have the courage to use them together. Usually, I'm a little bit conservative about using the cyclosporin in general, either surgically or medically. So even in my surgeries, I'm not using cyclosporins a lot. But I think they can be used together, but I prefer to use the non-steroidal, which is the Xiidra, first as a step, and then, if needed, I can think later on of using the cyclosporin if the patient needs something like this.
Thank you very much.
Please. Mike.
My question, when to use Xiidra, when to use cyclosporin, when to use steroid?
This is a great question. So, steroids sometimes is needed if there is associated severe inflammation of the eye. Usually I'm trying to start with the steroids first, with the use of the artificial tears, of course, and then after tapering the steroids, I start the Xiidra. In the mild cases, I can start with the Xiidra directly without the use of the steroids, with the use of the artificial tears. As I mentioned just a moment, I don't use cyclosporin a lot. I can try the cyclosporin in the severe cases of dry eye, which is not responding either to steroids or the non-steroidal medications.
And you start with the fluoromethylone or what?
We usually, it's not available a lot here in so yeah, usually I was starting with the fluoromethylone, just fluoromethylone, but here in Emirates we have the Lutimax. I start the Lutimax first, which doesn't increase the intraocular pressure and gives a very good response, and the form, which is the eye gel form, not the eye suspension form, gives a very fast relief of the symptoms and signs of the patients. So usually I start with Lutimax or the fluoromethylone, and then I can give the Xiidra with the lubricants.
Okay, and when to stop the Zytra or Leftigrast after 2 months or forever? What?
Usually, I follow up the patient every month for the first 3 months, and then I reassess the patient again. And if I found an improvement, I keep it on this Zytra for another 3 months, so total 6 months. And this after the 6 months, if the patient comes back, so I start to taper the patient, because you know that these patients are chronic patients and they don't feel that the urge to come back for follow-up. But usually when they come to follow-up, I have patients coming for about 2 years now for their dry eye medication, and I'm writing for them, because when I start to withdraw the Zytra, the patient starts to feel the problem again. So usually I continue it for at least 6 months.
خرافي. دكتور تامر كان
مين فينا؟ أيوة.
Yes.
دكتور محمود.
Thank you for the nice presentation. Actually, it's I'm personally, I don't have a lot of experience in Sidra. I just had a couple of samples to use. And it's a breakthrough. But how long you will keep the patient with Sidra? Is this forever, like the peer substitute, or how long?
I was just telling Tamer now that I'm trying to give the patient the treatment for a month first. If he came with improvement, I continue for him for another 3 months, and then reassess after this 3 months. And if I find him satisfied, I continue for 6 months. If the patient is not satisfied at this 3 month time, of course, we'll stop the Zytra and think about other alternative. But I try to keep him up to 6 months at least. I had a couple of patients followed up with me, as I mentioned, 2 years now. And when I started to withdraw the medication after 3 months or 6 months, they started complaining again. So I'm still continuing on them.
Okay.
Okay, I have one question. First of all, thank you very much for the interesting lecture. And I have a question. What's your experience with Zytra in patients who underwent cross-linking for keratoconus, and in patients who underwent refractive surgery? I saw the case about PRK, but people who underwent, for example, LASIK and have MGD and dry eye long-term, and how long would you keep them on Zytra, or would you combine Zytra with lubricating drops for years and months on? What's your strategy?
Usually, in my cases of laser refractive surgery, I give the patient instantly lubricants for at least a month, 5 times a day, and then I try to give them this lubricants 3 times a day for another 3 months. I started with this patient because he had this post-PRK haze on the cornea, plus he didn't use any lubricants after the operation. So I started immediately with the Zytra because it decreases the inflammation. Thus, I was hoping to decrease the the corneal haze happening to him as well, with the stronger effect on his eyes, as he didn't use lubricants. So I gave him both the lubricants as well as the Zytra, and he improved within 5 to 6 weeks. I still continued giving him this drops for 2 months, and I asked him to come back, but he didn't come back. In general, I'm not using this non-steroidal Zytra for as a post-operative management. So if there is an association of severe dryness or moderate to severe dryness or inflammation of the eye, and the patient is using lubricants already, so I try to add the Zytra to decrease in his problem.
But what about patients who underwent cross-linking and have post-operative haze after cross-linking? Would you recommend using Zytra?
Cyclospore.
No.
Cyclospore.
I don't like to use with keratoconus and cornea with the keratoconus is very complicated issue. So usually I preserve Zytra for other cases.
Thank you.
Dr. Tamer.
Dr. Ahmed.
As you know, I like to use cyclosporin.
Yeah.
And I've been using it for all my cases who have haze post-operative,
or
because
dry eye.
for PRK cases, complicated microkeratome cases, or any patient who have haze or healing problem in the cornea after the epithelium is healed. And of course, you use lubricant with vitamins that are available in the market, plus also mild steroid like lotiprednol, Lotimax. And then for any of these cases, I use cyclosporin. But I keep Xiidra for cases who have ocular surface disease, including dry eye plus or minus dry eye. So I put them in two different indications. Till now, I didn't have the courage to use cyclosporin with Xiidra, but in cases maybe in the future, I would like to try the cyclosporin 1%, which is the double, which you can use once in the evening, and it's already included
With the Xiidra in the morning.
with the Xiidra in the morning. Maybe I will try.
Can do
the
double
problem-
effect.
The problem, the insurance will not approve both probably, although they are two different ingredients. And because they are very expensive, they would not approve it. And patient
It's not approved easily, Kamal.
Okay, it's not approved easily, each one of them. But maybe.
I totally agree with you, but the main problem now with me that I don't like to use cyclosporin. You have this courage to use it, and
But it works. It works
Yeah, I
with
know.
with patients even who have subepithelial infiltrate, post-adenoviral. It improves their subepithelial infiltrates definitely. I saw a lot of cases who did.
and they are approved by the insurance.
Yes.
That's good.
It was approved. Of course, you don't put subepithelial infiltrate as the main diagnosis. You put keratoconjunctivitis sicca, dry eye, conjunctival xerosis, all of that. But I saw cases who, and I
Marginal gland
use it,
dystrophy and this.
and you use stasis with them, it improved. Post-cross-linking, the haze improved. So cyclosporin for haze.
I use this Xiidra in this post-PRK haze, and it's decreasing it
but
gradually.
it does not improve fast as with
Yeah,
cyclosporin, I
for
think,
sure.
yeah.
Because it's not steroidal. So it's a bit weaker than the steroids in general.
Okay.
Thank you.